cannot advance the slides. Okay. So even in skilled hands, if you treat a sufficient number of patients, you will encounter challenging adverse events. So how to prevent them? You have to carefully select the patients, to carefully select the device and the parameters, the appropriate laser parameters and techniques, and you should initiate prophylactic therapies when needed. This is a nice table by Dr. Ulster et al. Showing what you need to ask in a pre-op visit. Medical history, excessive scarring, underlying inflammation or immunosuppressive conditions, history of HSV, isotretinoin use, current medications, prior aesthetic treatments. You should look at the skin and check the phototype, the type and location of the lesions, and the presence of inflammation or infection at the time of the surgery or the laser, and the evidence of recent sun exposure on treatment sites. And very importantly, to educate the patient, to enforce realistic expectations, and to ensure post-care compliance, especially sunscreen. Post-op care is very important. It expedites resolution of symptoms and minimizes complications. And when you use occlusive ointments or dressings, it can prevent crust formation, it can help reepithelialization and reduce discomfort. And of course, this should be coupled with sun protection and sunscreens. So how to prevent and treat adverse events? Do not perform a procedure that might produce a side effect that you cannot recognize and treat. When recognized and treated early, you can decrease the severity and the duration of the adverse effect. For example, this patient had prophylaxis for HSV, but she still got it, so you need to know how to diagnose HSV and to treat accordingly to help remove or to help cure the patient and prevent any sequelae. So these are the patterns of resurfacing of the skin, the non-ablative, the ablative, and the fractional resurfacing. The non-ablative fractional coagulates the skin, produces columns of coagulated skin, whereas the ablative fractional removes or ablates columns of the skin. And I will be discussing the adverse events of the above too. So we start with the non-ablative fractional resurfacing. Really, there's no specific therapeutic endpoint, and any immediate endpoint suggests dermal necrosis. So we really need to be careful about proper dosimetry in these cases. The primary adverse event is post-inflammatory hyperpigmentation, particularly for dark-skinned individuals. And this results because of increased thermal injury leading to excessive inflammation. This will lead to unwanted pigment production, like we see in this patient. She had pigmentation on her upper lip. Luckily, most of the time it's temporary, and it resolves over the course of several months, and you need to treat with bleaching agents. How to prevent post-inflammatory hyperpigmentation in non-ablative fractional resurfacing? Density is the key, so decrease the density of the laser treatment, especially in dark-skinned individuals. Adjunctive cooling, lengthening the laser treatment intervals, so stretch the treatment intervals between 4 to 6 weeks, and pre-treat the patient with bleaching creams with strict sun protection. You can get acneiform eruption or melia, and this usually can be treated with regular acne medicine. Pinpoint hemorrhage, especially in patients with rosacea, which resolves with no sequelae. Blistering and crusting, this can occur due to excessive treatment coverage, so be careful because this can result in scarring if not treated properly, and the hypertrophic scarring can occur. Therefore, you have to really be extra careful when treating small areas such as the upper lip with high energies, because this can lead to bulk heating and scarring. Ulceration, we reported this case of ulceration after intralesional lidocaine injections for anesthesia, so I would advise you to avoid this, just use a cream. The ulceration resolved with proper wound care. Reactivation of herpes infection, as Dr. Cohen mentioned, it can also occur with all types of laser procedures, and we have to give the appropriate prophylactic treatment. This patient, I just saw her 1 week ago after non-ablative fractional resurfacing. She had this rash, and looking closely at it, there are some vesicles. This is her first episode, so she did not receive prophylaxis. So proper recognition of the rash or the HSV can prevent sequelae. This is a patient, she had reactivation of herpes infection, although she was on prophylaxis. So she got the right treatment and she did well. Now moving to non-ablative lasers. And we start with the hair removal. And the most common laser treatment is hair removal. It's usually safe and effective in skilled hands, and usually 6 treatments and you get good results. Red and near-infrared pigment-specific wavelength are the ideal lasers. They target melanin in the hair bulb, and the best candidates are light skin color and dark hair. Coarse, thick hair responds better than thin, vellus hairs, and blonde, red, gray hairs do not respond. This is the appropriate clinical endpoint when you see this perifollicular erythema and edema. So some tips: never treat when suntanned. This will give you obvious, bizarre appearing hypopigmentation. And if hyperpigmentation occurs, wait till it's gone before you treat again. Make sure you have adequate epidermal cooling. And there are multiple lasers and light sources that are available, so choose the appropriate laser for different skin types. Because if you choose the wrong laser or the wrong settings, you can get pigment changes or scarring. Be very cautious with darker skin types. Always perform test spots, use longer wavelength, longer pulse durations, and use bleaching creams before and after treatment when needed. The adverse events of laser remover include hypo and hyperpigmentation, blistering, scarring, and paradoxical hypertrichosis. Example of hyperpigmentation in dark-skinned individual, extensive dyschromia due to inappropriate fluence and pulse duration, poor technique, resulting in bizarre growth of the back hair, hypopigmentation when treating this patient while she stands, and scarring, and still can get scarring if you use aggressive settings or the wrong laser. Paradoxical hypertrichosis, you can see in this patient, you get this growth of more hair at the edge of the treatment. And the high-risk patients are women of Mediterranean descent with skin phototypes 3 to 4 who receive laser treatment on the face and the neck. Commonly affected areas include the peripheral edges of the treatment zones, and this is due to induced hair growth, which is typically observed with the use of low or subthreshold fluences. So how to prevent paradoxical hypertrichosis? You should avoid subthreshold fluences for future treatments. And when it happens, you can treat it with moderate to high fluences to the sites of the secondary hypertrichosis. Moving along to pigmented lesions, melanin is found within melanocytes, keratinocytes, and or dermal macrophages, and the Q-switch lasers are the treatment of choice. Long pulse lasers and light sources can also be used. So all these are the benign pigmented lesions that are amenable to laser or light therapy: lentigines, freckles, nevus of Ota, E2, and café au lait macules. However, if you have any index of suspicion of any of these being malignant or an atypical nevus, you should perform a biopsy before you fire your laser. The endpoints are, it depends on the pulse duration of the laser or the light source you're using. So Q-switch lasers will cause immediate whitening. However, if you're using long pulse lasers and light sources, you'll have subtle darkening after a few minutes. So this is the right appropriate endpoint when you're using a Q-switch laser. What about the adverse events? It can be pigmentary or localized chrysiasis, and we'll talk about it. Pigmentary changes include hypo and hyperpigmentation that are similar to tattoos but to a lesser degree. And sun avoidance and broad-spectrum sunscreens are essential. Patient treated with Q-switch Ruby, she is dark-skinned and she got hypopigmentation. Luckily, this resolved with good clearance of her café au lait macule after multiple treatments. And this is a patient who was treated by a non-physician with IPL device that caused hypopigmentation that can be permanent. So do not treat tanned patients with lasers. Localized chrysiasis is another important side effect, where you have this dark blue pigmentation caused by the Q-switch laser treatment in patients with any history of gold salt ingestion. This is due to physiochemical alteration of the dermal gold by the laser. So if it happens, it's really difficult to treat. Therefore, you should be really cautious, and you have to get the history of gold ingestion before you use any Q-switch laser treatment. Moving along to tattoos. The gold standard is Q-switch lasers, as you know, and the clinical endpoint is this immediate whitening, which is corresponding to the small gas bubbles that are formed in the dermis. Allergic reactions to tattoos can happen even without firing a laser, just by placing the tattoo. It could be localized or systemic. The green, blue, yellow, and red colors can cause allergic reactions. The yellow color, cadmium sulfide, can cause phototoxic reaction, and manganese or purple, or the purple color can cause granulomatous reactions. However, sometimes you get allergic reactions when you fire a laser, and this due to laser-induced extracellular fragmentation of the pigment and mobilized the pigment. This will lead to a foreign antigen-like lesion in the skin that will lead to allergic reactions. And this is an example of allergic reaction after using Q-switch laser to treat red pigment in the tattoo. So another side effect is laser-induced tattoo ink darkening, and this is due to reduction of metallic compounds. Sorry. So, for example, ferric oxide, which is brown-red in color, used in multiple red and pink and fresh-colored tattoos, it can be reduced to ferrous oxide, and the color will be jet black. And if you, the titanium dioxide, which is the white color used to enhance multiple pigments, enhance the brilliance, it can be reduced to a blue color. So you need to be careful and when you're using, sorry. So to prevent it, you have to practice extreme caution when you're using, I'm just going to go back a little bit. How to go back on the right side, right? Okay. So caution when you're treating cosmetic tattoos because they can turn black, like this patient. And to prevent it, practice extreme caution in cosmetic tattoos. Use a single test pulse to check if there is darkening. If there is darkening, you can stop the treatment. And if it happens, you can use lasers again to remove it. Not always it will help, but it can help in many cases. Hyperpigmentation can occur with all Q-switch lasers. Usually it's temporary, but it can be long-term. So in hyperpigmentation, the greater risk is in patients with skin type 3 or more, and they use the 1064 nanometer Q-switch Nd:YAG, which is the laser of choice of dark-skinned patients and least injurious to melanocytes. Scarring is very rare, but the risk factors include higher fluences, multiple treatments, and double tattoos. And this is an example of hypopigmentation and scarring after Q-switch ruby laser. Traumatic tattoos, they can have all these ingredients, asphalt, gravel, earth, vegetative matter, but they can sometimes have gunpowder. So you have to be very careful. If you suspect gunpowder, do a test spot, and if you see an abnormal reaction with sparking or transepidermal pitting and or smell of burnt sulfur, you should stop the treatment immediately. And finally, vascular lesions. Vascular lesions, the target chromophore is hemoglobin, and the treatment of choice is pulse dye laser, emitting light in the yellow visible spectrum. There are other vascular lasers and light sources. What are the endpoints? And I advise you to go to look at this article by Dr. Warner et al. About the therapeutic endpoints. Immediate purpura is the endpoint of choice for port wine stains. However, if you're treating telangiectasias, you can have immediate vessel disappearance or vessel darkening, and this depends on the pulse duration that you're using. This is immediate purpura for a port wine stain on the trunk, and this is the transient vessel darkening, as you can see below, and here's the vessel disappearance. All are appropriate endpoints, and they correspond to the pulse duration you're using. However, there are warning endpoints, such as metallic gray blanching or second-degree burn with blistering. These are after 755 nanometer alexandrite laser treating port wine stains, so be careful because they can induce scarring. So the complications of vascular lasers, pigmentary changes, especially in darker skin types, post-inflammatory hyperpigmentation, it is the most common. Usually it's transient, resolves within 2 months. Post-inflammatory hypopigmentation, it's usually transient, however, it can be permanent. And scarring can happen, it's rare, and other footprinting, crusting, and dermatitis. So this is an example of hypopigmentation that is permanent from a PDL on a skin type 5 patient, scarring from argon laser, scarring from Nd:YAG laser, footprinting from poor technique with PDL, crusting from pulse dye laser. Here it's so important to do very good post-op care to prevent scarring. And I'll end up with this case which we received on our VBF, Vascular Birthmark Foundation group, a surgeon who didn't have much experience in laser. This is immediately after pulse dye laser. You can see the sloughing of the skin, second or third degree burn immediately after. And here, 1 day after, 2 days after. So we ended up from a pink port wine stain to a scarred port wine stain. So in conclusion, complications can arise from any laser procedure. Good practice and common sense can minimize complications significantly, and do not perform laser procedures if you cannot recognize and treat possible side effects. And thank you so much for your attention.